check everybody's got copies of agendas. Yeah. Check that everybody can hear us on Teams.
Yes, thank you.
On that note, then I'll start the meeting. I'll look to my left, Company Secretary, welcome and apologies. Any apologies, please?
Yeah, thank you, Mike. In addition to apologies from Tony Oatman, we've got apologies from Tabitha, and he's here on behalf of Tabitha, and we've had apologies from Saxon. Are there any other apologies that we need to record?
No. Thank you. Any declaration of interest? No. Can I go through the minutes of the Board of Directors meeting then? People are happy to approve the meeting on the 7th of February?
Okay. Just one thing, and it was, I think, related to the patient story, and I wasn't in, so there was a mention of JW, but JW wasn't mentioned in the names, so that was just a missing thing, unless I've missed it. But
We'll take them as an action.
Yeah,
Thank you.
you're correct.
Thank you, Jay.
Okay. Based on that correction, happy to accept?
Yeah.
Thank you. Action sheets and matters arising?
No particular matters for the public board agenda today, Mike. You'll know that there was a request that as we look at our forward plan for next year, we include something on kind of research and that will feature in part 2 of today's board agenda. Thank you.
Thank you. And colleagues, we'll move on to item 187, the patient story. Welcome, Jodie and Alex. Good to see you. I'm going to ask Lynn to lead us into this item, please.
Thank you, Chair. So I'd like to introduce you to Jodie Birch, community physiotherapist, and she's here with Alex, who's come for support. You're the clinical lead occupational therapist. So the story today is a story outside of hospital, which is really welcome, and it's about independent living and shared decision making. So over to you.
Thank you. Yeah, thanks for having us. This is Jodie and I'm Alex, and we're a physio and occupational therapist, and we work for the Community Therapy Rehab Service, covering the South Lakes locality, and we provide physio and occupational therapy rehabilitation to patients living within the South Lakes. And we thought that it would be nice to start our patient story presentation with a quote from the British Geriatric Society about the importance of rehabilitation, especially for older people being discharged from hospital. They experience it without rehabilitation. They experience a lot further deterioration on their own health within their own homes, and also there's a 15% chance of them being readmitted to hospital within the first 28 days of discharge. So we thought that was a nice slide. So if we could have the next slide, please.
So just a bit of background for this patient. So before all of this happened, he was a very fit, active 95-year-old man. He was walking the fells, climbing mountains. He did have some spinal stenosis, which did cause problems, but generally he was very active. He decided one day to get up on a stool to get something out of a wardrobe, and he fell backwards and hurt his back. So initially he took to his bed for a couple of weeks, thinking that would sort of sort it out. Unfortunately, symptoms progressed. He got double incontinence, sensory and motor issues, so he wasn't able to walk. His GP thought he had cauda equina, so he was sent to RLI with the plan to go to Preston, but he did stay at RLI. They diagnosed SC6-7 stenosis and disc extrusion, which was causing a cord compression. And it was decided that he wasn't for surgical intervention, so he was discharged home around May of 2022 with supported discharge and a full hoist and a tilt and space chair and a full care package 4 times a day, QDS. Double ups, he couldn't fit, he had no sitting balance. So supported discharge, initially they worked on his sitting balance, and then eventually they managed to progress to standing hoist. By September, he was managing to stand for very, very short periods, like 10 seconds with the standing hoist. So they then asked us to get involved. Yeah. And there was some joined up working initially. So there was that smooth transition of care where we could learn about the piece of equipment and get to know Mr. W, and he could get to know us. And then we took over that rehab.
Yep.
So we were going 2 to 3 times a week initially, and working on that standing balance regularly so that he got that opportunity to strengthen himself. He was eventually going from 20 seconds standing, and then his legs were giving way, to eventually 2 to 3 minutes standing. Next slide, please.
Next slide.
Yeah.
Thank you.
Eventually he managed to get to a point where he's consistently standing for 2 to 3 minutes every single time. So we then asked the carers to come and assess that with us, and they were happy to continue that with him. So the carers were then doing that with him, which allowed us to step back a little bit because he had exercises ongoing that he could do himself. Eventually with the carers, they reported that he was managing to do 2 to 3 times a day standing for 5 to 6 minutes. So we then went back in and assessed that and decided that he could maybe progress on to a Sarah steady. So if you don't know what a Sarah steady is, it's a non-electric stand aid. So it means the patient has to pull themselves up to stand, and then it's got some little seat paddles that come behind them so they can sit and perch. So he started practicing that. He was very good, very consistent with that, and was managing to do 90-degree transfers. Next slide, please. So again, once we felt he was consistently managing that, we handed that over to the care team. So he carried on with the Sarah steady. He was consistent with the Sarah steady. So we did go back to review him in March last year. So that was like a whole year almost since discharge. And we were going to look at progressing him with his walking, and we did try with a gutter frame, but he just had no control of his legs and he wasn't aware of where his feet were being placed on the floor. So at that point, we sort of came to a conclusion that he was sort of plateaued at that point. And from my point of view, he was discharged with his ongoing exercise programme. Alex was still involved from an occupational therapy point of view.
Occupational therapy stayed involved really because there were some long-term issues with adaptations in the house. So we did make some referrals to the local authority because it was around large adaptations that we couldn't support with. And also there was issues with his wheelchair. So we were working alongside the wheelchair services down in Preston to try and find better solutions for his wheelchair. However, there were different episodes of care, so we weren't involved. We had discharged at appropriate times and then got back involved as needed when other services and care professionals needed us to step back in.
When Alex went back in November last year to liaise with the social worker about various things.
Yeah, we went for a case review with the social worker because they felt that he had made significant improvements, so they wanted to look at discussing reduction of care package and various different things, and we actually found that he had improved significantly just from his own engagement and his own motivation and working with the carers. At that point, I asked Jodie to go back and review his mobility.
So we went back and we took a wheel Zimmer frame with us, quite optimistically thinking he might actually be able to manage something, and he did, and he stood to his Zimmer frame, and then he proceeded to walk around the living room with the frame with myself and Alex with the chair behind. So we've been working on practicing that, making sure he's consistent because his knee still he's a bit temperamental sometimes. And he was then going up and down the corridor about 60 metres, and now he's walking with the carers with supervision only around his flat. And yeah, he takes himself into his kitchen, stands up at the worktop, makes himself meals and drinks. Next slide, please.
So this is just a slide just to sort of demonstrate all the different organisations and teams that were involved in his care throughout the long breadth of time. I think overall we've been involved in and out with him about 2 years now. So that's just a diagram really of all the different teams that were involved, and the supported discharge therapy team almost set him up, his rehab up initially, and dealt with the essential rehabilitation goals, and then we took over shortly after. If you can have the next slide, please. So we thought that we would consider throughout the whole process what sort of things could be improved and what we could look at. And we felt that, especially from Mr. W's point of view, and I think that came through in his patient story a little, that possibly like improved communication, especially on admission for him, because he was 95 and I think he felt like he was possibly a bit written off, and he was told that he'd never walk again, he'd be fully hoisted. Could have potentially ended up going into long-term care initially as well, which would have cost him a lot more money than him going home to have the rehab sessions and to look at seeing if he could become more independent again. And also I think during rehab decisions, when he did plateau, he did feel a bit abandoned for a while because he was used to therapy going in and then he was discharged. So maybe we could look at how we communicated that better to him. He did have some short-term memory problems as well, which is you know, very common at that age. So I think we did obviously have to have numerous conversations with him around discharge, didn't we? And also the continuity of therapy services possibly could be improved because there's so many different pathways in the trust, especially for occupational therapy access. So whether that could be improved at all, because he did in the end have about 3 different occupational therapy services involved because he had the local authority as well. Continuity of care providers was a little bit tricky because he went through different care providers, because when he was first discharged from hospital, I think it was a hospital provided one, and then he went to a longer term package of care as a self-funder, and then when his funding, his own self-funding reduced, he had to be moved to a local authority approved care provider. So obviously that's difficult for the patient transitioning to different care agencies all the time, and it's more tricky for us because we have to provide you know, more communication and training to different agencies. The access to wheelchair services is difficult because they have long waiting lists, so we did have to wait a long time to get assessments and different alternatives for his wheelchair, and then in the end he did decide to go and buy himself a powered chair himself, because unfortunately the wait for chairs through the NHS is about 45 years for a powered chair. And then we thought for the bit more of a need for closer working with adult social care, because we did refer to the local authority to look at adapting his bathroom, and we thought if we had more knowledge around that and worked more closely with looking into DFGs and looking into bathroom adaptations, we would have known ourselves it was an inappropriate referral. So that was just a bit of a training need for us really, so we felt that could be improved. And could we have the next slide please? And then this overall sort of the end of slide really is just looking at the positives for the patient and the positives for the trust and how important rehabilitation is, and looking at it in a different way. So looking at the fact that we were involved in and out in timely episodes of care and providing rehab. The longer term effects of providing rehab for Mr. W in his own home has definitely reduced the service pressures for needs of sort of rapid response and district nurses. He was very prone to chest infections, and we felt that he was much able to manage those and be more resilient at home and not be as at risk of readmission, because he was stronger and he wasn't as frail, and he was able to be managed at home better when he had his chest infections. He had reduced hospital admissions as he's getting less, and he was generally improved resilience. I just said that. We're looking at reduction in care packages now because he was still having double up. So we've got a case review coming up, because there will be times of the day now he's much more mobile that he can have single carers going in. So saving money in that respect, and the patient-centred care and timely episodes of care, so we can step in and out as needed in the community. Also, the fact that he's now making his own meals and drinks and he can access the kitchen, and we've worked on his kitchen tasks. He's got improved hydration and nutrition. He can get himself his own meals and drinks, so he's much less likely to get UTIs and kidney injuries and other needs for obviously going into hospital. And then his overall improved mobility and strength will reduce his risk of pressure sores as well, which was a big need because he had lots of need for equipment for pressure sore reduction, but now he's much more mobile. We've been able to uplift a lot of that as well. And I also just wanted to say that I think it's really important to acknowledge the carers and the family, and the patient himself in rehab, because if you get somebody that's got really good activation levels and someone's really, really motivated, they're absolutely fantastic. The use of carers and families to help us, so it's reducing our time, and we support them to carry on the rehab, and then as and when we need to go and step in and they need extra support from the qualified therapists, we will. But that's really important as well. So from start to finish, I think we've made a lot of progress from him being fully hoisted and now able to, we've progressed to showering. He's made a lot of functional independence. He is able to go out in his wheelchair, so he's got a much better quality of life.
It just goes to show that, you know, sometimes it takes a long time for people to progress, you know, in working in the hospital. I know you see patients and they progress within a few weeks and then they tend to plateau, but when they get home, they carry on progressing in their own environment, and it just takes time sometimes.
Yeah.
He'll be 97, 98.
He's nearly 97 now, yeah.
Brilliant. Thank you. Thank you. I'm going to open it up for comments, questions about the chief
Thanks,
exec.
Chair. Alex, Jodie, well done. I know we were nervous this morning, so really well presented in terms of Mr. W's story. So I know this is one patient story, it's Mr. W's kind of experience with us. We talk as a board about integrated care being kind of one of our preferred ways of working. So supported discharge, community, therapies team, social care. How integrated was it for Mr. W? Did it feel seamless to connect and move through kind of making sure the teams were handing over and getting involved at the right time?
I think it felt integrated, definitely with supported discharge therapy team and the district nurses that we work alongside with and the social worker. I do think that sometimes it can be a lot more difficult because there's less occupational therapists in the local authority to get as integrated as we could, because we have to wait for referrals and then we have to wait for them to be available to assess. So we don't do as much joint working as we'd like, but we do have good communications with them.
Yeah, good.
Yeah.
If I can, Chair, just a quick follow-on. So you had a slide about areas for improvement. Another thing that the board's kind of sponsoring is teams feeling like they've got the permission and authority and autonomy to look at improvements and take them forward themselves, work with partners, try to get kind of improvement delivered. Is that something that's happening with the teams, given that reflection? Is there a programme of work or a series of things that are happening to improve in those areas?
Definitely, because we're currently just taking on the new CHC work in our team. So we've got channels now with Adult Social Care Weekly to have case discussions, which is just overall improving our communication and joint working more.
Fabulous. Well done.
Yeah.
Thank you. Good.
Adrian?
Thank you. I mean, my question was going to be Aaron's point, but I just wanted to have a little bit more detail. I mean, the return on investment is really clear for the patient, the trust and the wider system, but it was about that information sharing, the case management. Can you just tell us a little bit more about the tools that you use and whether you felt there ought to be any improvements at a system level, which we might just be able to support in some way through the work of the board?
Do you mean sort of things like discharge reports and
Just because you're interfacing with a lot of other partners internally and externally, and I just wondered, is that as basic as being on the phone? Is it based on personal relationship?
Trust, it's very good because we have a lot of Teams channels that we have set up with different groups of people, so we can communicate with our colleagues in the trust, RLI, FGH. We struggle quite often when people are coming from places outside the trust, like Preston or Manchester, then it's challenging to get the information.
It's the patient record systems that are the challenge, which has been like a real big challenge, especially between UHMB and the local authority. It's much easier when we've got teams that are on EMIS, because within patient permissions we can get shared access, so that makes it much more seamless because we can read, you know, all the recent interventions and previous, but we still have massive challenges with being able to share information with the local authority. I think that's been raised and escalated a lot. So that would be wonderful if something could be sorted for that. That would absolutely would change and reduce a lot of effort and time, wouldn't it? Trying to chase and make phone calls. Yeah.
Thank you. That's really helpful.
I'm going to go Scott, Sarah and Amin.
Thank you. I'm Scott. I'm the Chief Operating Officer. It was a great story. And one of the points of the story is to kind of pin the story to stuff that the board discusses a lot. And there's two things really strike me from your story. One is the Cod Equina pathway, which is really difficult and needs a whole other pile of work. But it really strikes me, and I'll use the word deliberately, that the work that your teams did rescued Mr. W from being codified in hospital for hundreds of days as not meeting criteria to reside and ending up in institutional care, and probably immobile, and then all of the consequences that come with that. So, and I guess to date, if we look today, we've got about 110 patients today that don't meet criteria to reside, another 60 that aren't therapy fit. So I guess my question is, what was the sweet spot that allowed you to rescue Mr. W from that and take him into the pathway that you did, as opposed to him going the other way?
I think they must have identified that he had rehab potential on the ward in order for him to go on the supported discharge pathway.
Okay.
They had to find specialist equipment for him to be able to progress from a hoist.
Okay.
He wasn't standard stock, so I think that because he needed the intervention of the OT to continue at home, it then got passed to us, because obviously they have a very short space of time. They only deal with the essential discharge needs. So I think because he was showing progress, they would refer straight to us if they still had rehab goals.
Okay, that's helpful. Thank you.
Thank you. I've got Sarah, Min as well, and Karen as well. I'll bring Karen in at the end if that's okay. We are a bit pushed for time. I think we could spend like 2 hours talking to you about this. So apologies to colleagues, but we'll contain it after Karen. Sarah.
Thank you. Thanks for the presentation. I agree with Scott. I'm Sarah Rees. I'm one of the non-exec directors, and I'm actually buddied with the community care group as well. So I've been out to services in South Cumbria. So it's really great to hear the story. I think what's really important for me as well is that point you made about avoidable or reducing hospital admissions. And I'm not expecting an answer from you on this, but I wonder if we could quantify what potentially we've saved in terms of avoiding those hospital admissions, because I think sometimes the work we do in our communities, perhaps we don't notice the impact so much in terms of reduction on demand for acute services, and that would be really helpful, I think, in helping us to understand what the community care group brings and how that can help us as part of our transformation.
You don't have to answer that.
No, you don't have to.
One of the execs. We'll take that.
Yes, thank you.
Yeah, thanks, Sarah.
Yeah, my name's Amin. I'm one of the non-execs. A really interesting story and a really good news story as well. The points about the improvements that have been made by the chief exec are a good point as well. But an apologies in advance for this. It's not a question, but I guess it's more of a point. In the story, I noticed that, of course, as an individual, there was one aspect that Mr. W maybe played a critical part of, aside from the motivation, which was a wheelchair element. If that wasn't possible for him as an individual, then what might that have done? And how do we remedy that? Because there may be other people that may not be in a fortunate position as Mr. W. So it's just a point, and I guess it's more curiosity more than anything from my perspective, really.
So yeah, so often if people can't self-fund the powered chair that they would like because to be more mobile around the house and in the community, they do go on to a long waiting list. But the only thing that we can access is if they've got the ability, upper body wise and upper strength wise, is a self-propelled wheelchair if they can manage that. But other than that, unless we look down charitable routes and things, and if they've got family, sometimes do support them as well. But we have limited options to get them anything else other than just that self-propelled wheelchair to make them a little bit more independent.
I'll ask the chief exec from Alex, but how much are electric wheelchairs powered?
It all depends on what type you need, really. But I think they're very expensive. £2,000 or £3,000 probably, and I think the indoor ones probably slightly cheaper, and the outdoor ones need to be more robust. Yeah.
I've just picked up two themes to play back, which I'll pick up with the exec team. One is Scott's question about how easy is it to access the right pathways from our wards to make sure that patients get into the right areas of care. This was one example, but there may be others. And the other I've written down is, what are the issues around rate limiting factors of equipment availability, and what's the impact on things like not meeting criteria to reside and discharge? Now, we have a sum of capital money that we use, but the NHS is awful at sharing money and seeing where you might deploy it across partners. but I'm going to ask the team to consider how else we might deploy our own resource or talk to partners about securing better equipment to support this kind of work. Because to Sarah's point, I think it would help on our own flow, discharge, quality and safety metrics, and we need to consider what that looks like. So no offer, but I'll ask the team to think through those two themes in particular, Chair.
Thank you. Very helpful. Karen?
No, thank you. My questions have already been addressed through Scott's and Sarah's questions, but thank you.
Thanks, Karen. Thank you. Lynn, do you want to say anything?
So thank you very much for your start. I mean, it's really complex, isn't it, even for one patient, but
And that's what we're seeing a lot of at the moment in the community, is a lot of complex patients.
but it's just a really good example about how teams working together and with the patient and family can have such a positive outcome. And it's what we would want for our parents and we'd want for us when we get older as well. So thank you very much.
Thank you. Thanks for having us.
Thank you.
Thanks, well done. Thank you.
Okay, colleagues, we're happy if we move on then to Chair's report. You've got it in front of you, so I won't go through it, except to bring just two quick items. Item 7, just to inform the board that the Council of Governors Nominations Committee met a couple of weeks ago, and we're now going out for a recruitment of a new non-executive director that will serve as an audit chair. That's based on auditor's advice, and one new associate non-director. We'll be looking for somebody to come in as the associate non-executive director who hopefully has real life experience of being a patient or being a carer, but at least some real life experience of what it's like to be at the end point of NHS care. So we'll see what we get into that. There will then be an associate NED vacancy, which we're not going to fill, which is going to keep it there because I don't want the board to get any bigger, because the nomination committee also agreed, and I've shared this with the chief exec, that we're going to ask the University of Cumbria if they would nominate somebody as a board advisor. And that's related to my next item. It's just to inform the board that that will be taken forward, but we will only be advertising for one associate NED. We'll keep the other as a vacancy. On item 8, you'll see that we've done a really good welcoming MOU, Memorandum of Understanding, between the Trust and Lancaster University. That's really gaining strength, and really there's quite a number of activities happening now, which are reviewed by the execs on a 6-monthly basis. And we're also looking to engage in a similar partnership with the University of Cumbria, hence the suggestion that they come on the board as an advisor. And then we'll review that on an annual basis. Happy to answer any questions. No? Are you happy to accept the chair's report? Thank you. Chief Exec report then, please.
Thanks, Chair. Just 3 or 4 items that I'll pull out of the report that's in the pack. Firstly, you'll see at the start of the pack a reflection of operational pressures. I know I do this through the winter period every board, but it's important I recognise it at every board because it is still an issue and our teams are still working incredibly hard every day to make sure that we've got access to safe urgent care in particular. This week's probably been our most pressured at the start of the week in terms of the numbers that we'd seen, particularly through the Royal Lancaster Infirmary with in excess of 40 decisions to admit in our unit in the morning. That's patients waiting for beds overnight that we couldn't admit. And that creates safety concerns in A&E. Really confident that particular focus of Scott, Jane and Tabitha with the care group triumvirates did a great piece of work over the course of yesterday with partners to ensure we decompressed and improved flow yesterday. But it's just the recognition that things aren't operating quite right in our urgent care system and it's creating risk in our A&E departments. We do have a programme of work or a couple of programmes of work around this actually. One is the whole system flow transformation programme, which Scott leads. The board will see updates of that through our transformation and improvement board in due course. And we also have some work happening under the recovery and transformation banner with the ICB, we will want to promote and prioritise that urgent care improvement piece at pace this year. So we're in a better shape for next winter, and we'll update on that through the provider collaborative board arrangements. The second item that I want to draw colleagues' attention to is the announcement of Martha's Rule with effect from April 2024. And I've circulated a briefing on that ahead of the board. Just to bring to life what that is for colleagues who may not be familiar, this is some guidance and direction for trusts following the death of Martha Mills, who died in 2021. Martha, young child, died after developing sepsis in hospital after falling off a bike. And after a review in 2023, the coroner ruled that actually Martha might have survived if she'd been moved to intensive care earlier, and some of the concerns of the families have been heard differently. Tragic case and a reflection again of what happens when things don't go as we would want in the NHS. So the three proposed components of Martha's Rule are: all staff in NHS must have 24/7 access to rapid review from critical care outreach teams, who they can contact if they've got concerns about a patient's deterioration. All patients, families, carers and advocates also have access to the same 24/7 rapid review from critical care outreach, which they can contact via mechanisms advertised around the hospital more widely if they're worried about the patient's condition. That's Martha's Rule. And we should have an implementation of a structured approach to obtain information relating to the patient's condition directly from patients and families, at least daily in the first instance. So there's three very clear components. There is a rollout of 100 trusts as a pilot of putting Martha's Rule into practice. Those 100 trusts should already have a 24/7 critical care outreach capability. We're just assessing the criteria to see if this is something that we could satisfy and be part of that pilot, but we're not waiting for that. We've already implemented a number of processes and improvements around Martha's Rule, so expediting the plan to provide contact details for the critical care outreach team, backup leaflets in terms of step up and step down patients. It will involve scanning a QR code and providing information to relatives who can contact us at any point. Putting out some comms and engagement piece out there so colleagues and patients know what our status is and how they can access that advice and information, and making sure that relevant members of the teams who are going to be, I guess, more connected to Martha's Rule. We're going to attend a virtual conference on the 14th of March, which will provide everyone with the same update. So we're not waiting for the pilot chair. We're taking forward some proposals of Martha's Rule now. One more, two quick updates. An important piece of governance and a piece of evidence for us to consider as a board later this afternoon when we talk about our SOF 3 to 2 improvement journey. I received a formal notice from NHS England earlier last month around our enforcement undertakings. And for colleagues, enforcement undertakings are placed upon a trust. They are statutory, they are binding, with specific actions that are required under our licence to deliver care. We previously had a number of licence conditions undertakings relating to quality and safety and finance. Some of those have played out in our recovery support programme, and obviously we've achieved the ambitions in that recovery support programme. The letter I've received issues a certificate for quality and safety, which means we no longer have any undertakings related to quality and safety. And I'll choose my words carefully. The NHS England are not minded to renegotiate any financial undertakings, and the ones that we had in place have now expired. They can't award a certificate on that basis because of the current financial regime and the position that we're in, but there will be no financial undertakings for our organisation. Another significant step, Chair, in our evidence base for improvement that we'll continue to build on as we look to next year and our further improvement plans. And then the final piece I'll update on is we're expecting a visit from Lancaster Medical School next week to review our arrangements for undergraduate medical education as part of our normal oversight of arrangements in that area. They're likely going to be considering how we'll ensure we get support for expanded numbers of students and how those arrangements can connect to our current workforce plans. So we'll be bringing the output from that review and any details on our response and actions that will follow to support that expansion at a future board meeting. We'll work with the company secretary to bring that to the board's attention, Chair, at that point. That's as much as I was going to update from our report. Thank you.
Any questions or points for the Chief Executive? Karen, please.
Oh, thank you. And thank you for that update, Aaron. My question relates to Martha's rule, and it may be that this emerges in the future work. It's really about how far that work to enable families to have access to that rapid review, how far we're going to ensure that that's really inclusive in its nature. Just really thinking about those families who we are less likely to hear from and who are less able to raise their concerns as it stands. So possibly different languages, taking into account people's learning disability and style. Will all of those aspects of inclusivity be included as the work goes forward?
Thanks, Karen. Yes, I'll make sure that the teams are aware that the way that we promote the offer of the support and advice and the information we provide, we'll make sure we make that as inclusive and diverse as possible. Yes.
Okay. Thank you.
Thanks, Karen. Harry?
I just wondered in terms of impact on the critical care outreach team, have we thought about that's going to already stretch capacity for that, what the impact is?
Yeah, so the first bit of it with around the QR code, it's patients that they're already reviewing a step down from ICU. But you raise a really good point, and in the guidance it does say there will have to be investment in critical care outreach. So our outreach is 12 hours a day at the moment, with support from senior nurses overnight. So it is further work that we need to do to make sure that there is equal access 24 hours a day.
Thank you. Colleagues happy to accept the Chief Exec's report? Thanks, Aaron. Head Governor's report, update by the Head Governor. Shirley-Ann Wilson, over to you, Shirley.
Can we take it as read, please, Chair? Thank you.
Okay, any questions to our Head Governor related to the report? Colleagues happy to accept the Head Governor's report? Thank you. Okay, we'll move on then. Quality and safety now. Item 191, Care Quality Commission update. Report summarise the current position for assurance. Lynn, if you could just explain why the paper is coming to the board first.
Yeah, I will. So this is a statutory requirement for reporting at Trust Board, and it's following the CQC inspection in May 23. There were 10 must-do actions and 11 of should-do actions identified. We've been working through those as a series of working groups looking through those. Since the last report at board, there have been 3 must-dos completed and 3 should-dos completed, and those actions cover maternity and medicine. We're aware that there needs to be more clearer timelines and expectations in the report, and we're working through that. We've currently got some sickness in the governance team, and that's the lead that would normally do this. So the CNO is working through that, and future reports will be with more sort of timescales and defined outcomes.
Thank you.
The other bit I just wanted to mention was the update on the new CQC methodology that's in the paper, just briefly. So the revised methodology is now live. There has been a board development session, which you'll be aware of. There's work ongoing with care groups to outline the changes and the development of an assessment tool to identify, it's almost like a gap analysis against the 34 quality standards. We are working through wider engagement with the teams on the new methodology right across the organisation, and we've arranged a listening event on the 23rd of April, which is, we're trying not to call it CQC work, but the title is Let's Talk Quality. So it's going to be based on a framework with the 34 quality statements, and if nothing at the end of it, we'll have got, you know, the good practice that we're doing benchmarked against 34 quality standards, a gap analysis where we need to do some work, but people will have been exposed to the 34 quality standards, and we're being supported that by the CQI team. So that's going to be a really interesting event. And that's all from that report. Thank you, Chair.
Sarah?
Thank you. Just to confirm that we considered this at Quality Assurance Committee last week. There were a couple of points where we asked for some additional assurance, but they were relatively minor points. They were more procedural around.
So nothing to escalate.
Nothing to escalate.
Adrian?
Thank you. Thanks for just sharing about the listening event. That sounds really interesting. And I just wondered how staff are engaging with this, whether they feel daunted by the prospect of a new standard, whether they feel that it's achievable, and it's just about supporting our staff to engage and embrace it really in a positive way.
So there's been a task and finish group which has been engaging across the organisation. When I've been talking to the nursing staff and the AHPs around the 34 quality statements, it actually feels much more less complex than the previous key lines of inquiry. So they are much more identifiable, and I think it will be better accepted by people at the front line, because they'll be able to sort of benchmark their practice against what is, to all intents and purposes, well, it is a quality statement, but they're clear and they're simple. So it's much better defined. We haven't had much pushback, and most people seem to be engaged with it. I mean, the proof of the pudding will be if the CQC came in and started to use that new methodology. The best that we could aim for, and that's what we are doing, is that people will be able to talk about the best practice against those quality standards, and that's where we started really.
Thank you. That's assuring that you're getting that feedback. Thank you.
Thanks, Adrian. Karen?
Oh, thank you. And thank you, Lynn. And my question is specifically about Appendix 3 and the recommendations following the well-led reviews. And it's just really noting that it looks, working through that appendix, as if we have quite a significant number of actions where the due date for completion is either February or then March. And just really conscious that those the dates for completion of those actions will have closed by the time we come to our next board meeting. And it's just really helpful. It would just be helpful to have an assessment of the level of confidence we have that all of those actions that are currently in progress will be completed by their planned due date.
When I mentioned around there needs to be further work, Karen, about those dates for completion, that's the work that we're working through, Richard and I, with Tabitha. So we'll have hopefully more detail at the next board. Hopefully is probably not the right word, but that's what we're aiming for, that we've got better defined dates. And where we said they'll be completed, they'll be completed.
Paul?
Just to give you some additional assurance, Karen, the reason why you've got those kind of deadlines there is that there is actually a scheduled piece of internal audit work being undertaken. So what we're doing at the process now is, having implemented various actions under the well-led domain, we're going through a process of evaluating the evidence, making sure that we've got them embedded and that we've got some assurance that, you know, we've made the changes required. To provide that additional kind of assurance, internal audit are actually doing an assessment now, and you'll see that feature in the audit committee, which I think will probably be April time.
Okay. Thank you.
Yeah, Paul?
Yeah.
Yeah, great. Colleagues, any other question? It is an assurance paper, but it is also a summarising of the current position. Colleagues happy to accept the paper? Yeah, we know it's work in progress. Lynn, thank you. Donna, welcome. We're moving on to item 192 now, maternity and neonatal update assurance report. Again, for assurance. I'll pass through yourself, Lynn, first.
Yeah, so I'll just hand you straight over to Donna, who's going to take us through a series of maternity reports. Thank you, Donna.
Good morning, everybody. I'd like to advise that we have undertaken our mid-February review with the Maternity Improvement Advisor, which is referenced within the summary of this report. This meeting was to look at the leadership challenges due to the changes that have occurred throughout January. Since the paper was written, I can advise the board that we have recruited an interim HOM who will be starting in April. We have appointed 2 matrons who will be starting posts within April as well. We are working closely with our maternity neonatal voice partnerships in relation to the development of the maternity strategy, and this also does form one of the CQC recommendations from our maternity inspection in 2023. The CQC survey was published last month in relation to experience within maternity services, and we're pleased to report that we had a response rate of 43%, and the scores in our CQC survey were improved from 2022. We will be doing an assurance paper which will be going to Quality Assurance Committee and be coming to board for April and then in May. In relation to the maternity dashboard, we have highlighted in relation to, we are undertaking a thematical review in relation to our data that we are seeing around women who are choosing to undertake inductions and have elective caesarean sections. The reason we're looking at this is because what we are seeing is a decrease in women who are going into spontaneous labour. The data we've already been triangulating is this is supporting 1, maternal complexities in pregnancy, and 2, we are seeing around personalisation and choice that women are choosing these options. I'd also like to highlight within the perinatal quality surveillance model that we're just seeing that theme coming through just around our bereavement services, which I articulated in the January board paper, just around the experience of not having the bereavement suite at the Royal Lancaster. I know there's a focus to see if this can be expedited to 2024 because of the finances, but we are still waiting to hear that outcome. I'd like to advise the board the women are offered an option of going to South Lakes Birth Centre who cannot have the bereavement suite at RLI, and they are for the well women, the vast majority of women who have suffered a bereavement, but the small minority of women who are poorly, and that bit might be because they've suffered an antepartum hemorrhage or there's a risk of infection, we can't offer this service. So those women are being cared for on our birthing suite on the Royal Lancaster. I'd just like to advise the board for assurance within this paper, and happy to take any questions.
Thanks, Donna. I'll ask Sarah Rees to come in first, just to ensure that there's no escalations or anything from the Quality Committee.
Yeah, thank you. Yeah, we did discuss this paper at Quality Assurance Committee. I think the other point I wanted to pull out was around the 8 postpartum hemorrhages, which are greater than 2,000 mils, and 3 returns to theatre. We did have assurance through the paper, through the committee, that 72-hour reviews have taken place and action's been taken to put a draft risk assessment in place currently, which will be rolled out in April. And the new interim director of midwifery also provided assurance that the trust performs better than the benchmark around the number of women experiencing hysterectomy relating to PPH. So that provided us with some additional assurance, I think, about how this is being managed and the impact of it as well. So that's the key point I wanted to mention.
Chief Exec.
Thanks, Chair. Hi, Donna. So just 2 quick questions for me. One is, well, they're related. So the NSSP, the National Maternity Programme Sustainability Plan, and the maternity strategy, do we have timescales for when we're expecting to see drafts or proposals of those 2 documents?
I can advise that we have a meeting set in place to complete the draft maternity sustainability plan between myself and Sue by the end of the month, the interim director of midwifery. We plan to take that sustainability plan through the quality governance assurance framework throughout April, if that helps support that question.
It does, thank you, Donna. And the maternity strategy?
The maternity strategy, the interim director of midwifery has 2 meetings set up with the maternity and neonatal voice partnerships coming up in the next 4 weeks. This is to work with them collaboratively around the strategy to help move that forward, because we just need that service user engagement.
Okay, thank you, Don. I'll pick that up. And it's just a question for the exec team, really. The question of the bereavement suite at RLI. I know we go through a risk-based approach which our oversight groups look at in terms of deployment of limited capital. I just think we need an answer as to whether that's going to happen in 2024 or not, to close the audit loop, and a justification of, if it isn't, what is it that we did to decide it wasn't. But we said as a board, best endeavours to see if that's something we can do in year. So we'll pick that up, Donna, and make sure that's done in month.
Thank you.
My question's related to that, Donna. We have women then who are in RLI, who are having surgery, etc., and then being placed in the same unit as other women who've got babies. What's the support that we're giving to those women that require what would be normally the bereavement space?
The women are told at the time when they are first informed of the sad passing of their baby, they are informed around the clinical situation and supported in the best way that we can. We try and absolutely minimise on a psychological level for the women. However, it sometimes proves challenging in a busy labour ward, but we are very open with the women at the start of the care pathway, of the bereavement care pathway, around their medical complexity as to why we can't offer them a transfer at South Lakes. So from a psychological perspective, when they are cared for on the labour ward, we minimise that before they're transferred into that room. We remove the cot, we remove the resuscitator, we make the room as friendly as possible in the most bereavement space that we can. But the issue around the patient experience, which is the feedback we're receiving now, is the hearing of women in labour and hearing of babies crying, which is the impact, and that's something we're not able to mitigate.
I'd like to ask one of the NEDs, please, if they would be willing to go and talk to the women in that unit and pick it up really straight from the women's experience. Anybody want to go and speak to the women?
Do
Do you mind?
Yeah, no, I can do that.
Well, what I'd like to find out, Donna, is what their perception of the support is, and whether there's any referrals through chaplaincy or bereavement groups or any other charities, etc. Just to get that devastating psychological impact, really.
Yeah, very welcome. I would just advise I contact all our bereavement ladies within the governance capacity, and we support them with Petals counselling, so a bespoke bereavement counselling. So I ensure that is offered to not just the mothers but the fathers as well. But a good forum to discuss this with for the non-execs, maybe to come to our maternity and neonatal voice partnership meeting, where this is also being raised through them.
Yeah. That's great. I'd still like one of the NEDs to be actually physically in the unit and actually perceive the noise that goes on, babies crying, women giving birth, etc. When other people are in a desolate space, really. I think that actual feel of it, I think will make us perhaps focus on it more. Okay.
Thank you.
Thank you. Any further questions for Donna on her paper? We're happy to accept it. Donna, thank you as always. We will no doubt see you in our next board meeting.
Thank you, everybody.
Thanks very much. Karen, sorry, Karen.
No, it's fine. Thank you, Mike. It wasn't in connection with with the maternity paper, but it just seemed a timely point to just advise the board that I'm in the process of handing over the maternity and neonatal safety champion role to Alison Cole. People are aware of that, but it's just really to formally advise that today. Alison and I, as you know, have been working closely together on this, and we are now working through that transition that is planned to be completed by the end of March. So by the time we come to the April board, Alison will be firmly in that role. But yeah, just to assure everybody that we're making that transition as seamless as possible, and for the time being, both being in contact with Donna and Sue Stansfield and Maternity and Neonatal Voices Partnership, but we'll be completed by the end of this month.
Thank you. Thanks for the update. Thank you. Donna, I don't know whether you want to, oh, she's gone again. Okay, then I was going to ask her if she wanted. Oh, Donna, it's up to you whether you want to stay for the next item 193. It's just the annual safeguarding report on the named midwifery annual report and named nurse children in care and child exploitation report, which is coming through the Chief Nursing Officer, Lynn.
It is. I'm going to hand you over to Dan West, who's going to present this report.
Dan, over to you, please.
Good morning. Yeah, sorry that took me a while to get connected. Yeah, thank you very much for allowing me to come and discuss these three reports. I suppose as a point of assurance, I'd just like to reiterate that there's been a internal governance kind of framework strengthening within safeguarding, which has led to the creation of an assurance board, which these three reports have been discussed. Which reports into our Quality Assurance Committee, and then of course coming here. The point I suppose I wanted to make was that it includes senior safeguarding colleagues from the ICB and also includes the chair of our Council of Governors and some senior care group and safeguarding staff within the Trust. So it's quite a well-attended and resourced forum. The three reports that I'll be discussing today or presenting today are the named midwife statutory report, the named nurse children in care and care leavers report, and the named nurse and the nursing report for child exploitation. I'd just like to draw attention to one or 2 points from the reports that we think are particularly worthy of noting. In the midwifery named midwives report, we very deliberately have put the voice of the child and statements of children that are supported by our service into the reports that you're seeing. You'll see that there is some duplication as well, and that's a very deliberate action because it speaks to the multi-agency collaborative approach that most of our children who require support are facing. So the child that is highlighted in the midwives report was also being supported by our child exploitation nurse and is a child in care. So it was just to kind of highlight the interconnectedness of it all. In the reports, the structure very deliberately has been created on what we think are the areas of importance for you to be aware of. So visibility, supervision, training, and of course, multi-agency working with colleagues, both within the ICB, regionally, and in some cases nationally. The named midwife report gives a good representation, I think, of how training compliance with safeguarding has improved over the year. Training compliance has improved over the year. There is one area that, because we did discuss this in Shadow Board yesterday, that I felt probably needed highlighting because it was brought up in that forum, so probably a deficit. But in terms of the continuum of needs that has been implemented in Lancashire over the last 3 to 4 years, you'll see where we talk about pre-birth and postnatal safeguarding. Some of the figures look like there's been a significant decrease in child protection plans, for instance, in the last 12 months. The reflection, I've gone back to our safeguarding team and the ICB to discuss this, and the reflection on that is that it's not unusual for them to see a variation in year. There's no specific kind of number that would be ascribed to this, but they do feel that the influence of Lancashire's change to the continuum of need has influenced this, in that we are prioritising earlier intervention into safeguarding with children and their families, and therefore the need to go to the top of the hierarchy, if you like, for child protection plans has been lessened. and I can discuss that a little bit later if there are questions from the board. In the Children in Care and Care Leavers report, it's a bit of an unusual and very specialised service, and so we felt it was important to not just kind of discuss with you what the service was about, but to say that there are challenges for this service. So therefore, that the slide that shows challenges and delays is again there very deliberately. The action that's been taken on this in collaboration with the ICB, we welcome, because our own nurses are there to facilitate the equity on access to health for children in care. We see that that's their fundamental role, but often children who come under our care are either out of area or have an aversion to authority because of their lived experience that causes delays in what is a kind of a metric, really, a 21-day metric. And the two areas of importance to know are the initial health assessment, which needs to be carried out within 20 days of a child coming under our support and supervision, and the review health assessment, which happens at a later date, which is subsequent to those things that have been identified in that initial health assessment, to provide sure it's assurance, but we're working collaboratively with our ICB colleagues on auditing this process with a view to improving the quality and the access for children. And that is going to be rolled out in April across the entire ICB with a big contribution from our teams, and with the view that there will be improvements from that. So access to paediatricians, access to dentistry, etc. So it's kind of a good news story, because we're actually looking at how we can improve services for this very vulnerable group of patients. In the child exploitation report, I think one of the things from this report which is important to take away, one is it's a very small service. The nurse who works within our safeguarding team actually is based in country, if you like. So they work in police stations and in kind of childcare child centres with police directly, with the children's social care teams, and their role is to bring that contextualised safeguarding and trauma-informed discussion, both from the experience of the team that they work with within our hospital and their experience, and to improve that for the children who are identified. We've said that there's a few numbers on there. There hasn't been a huge increase in identified children over the year, but I think that they have a growing confidence that there is more investment from the ICB and from children's social care in the importance of developing these teams to identify hotspots. Yeah, thank you. And I think those are the main things that I kind of wanted to bring out from the reports. Thank you, Chair.
Thanks, Dan. I'll just check again with Sarah Rees, Chair of Quality, that it's gone through any escalations.
No, yes, it went through Quality Assurance Committee last week. There were no escalations. One of the things Dan hasn't mentioned, but I think it's important we draw out as an example of good practice, is the co-production and children and young person takeover, which took place as part of co-design of services. And so I think that's really important to commend, and also then consider how we can use that in other fora to ensure that that patient experience and user experience is incorporated. So I wanted to add that. I did just want to ask a couple of quick things, if that's okay. Dan, you mentioned that there's now an audit process to look at improving quality of access. It would be helpful, I think, to receive an interim report to Quality Assurance Committee at an appropriate time on that, if we can add that to the forward plan. And then
no problem.
Thank you. And then the other point was just, you mentioned that the children in care team is very small. I couldn't quite tell from what you said whether it's one nurse, and just considering if we've got any challenges around resilience of the service, and then how that is matched potentially across the ICB.
Team of one.
Yeah, exactly.
I was going to say.
Yeah, I'm happy to answer that if
yes, please.
Yeah, so the child exploitation nurse, you're correct, is a single person, but they work hand in glove with our child, with children in care, and so there are a team of three, but admittedly it's not very big. But we've tried to make sure that wherever possible, there's cross cover and support for all of the nurses working both within children in care and care leavers and child exploitation. So they work with an interdependence, just so that we can kind of strengthen and make it more resilient.
Thank you.
Aaron, then Adrian, please.
Thank you, and thanks, Dan. And this may not necessarily be a question specifically to answer today, but having seen these reports at Quality Assurance Committee, I've just been reflecting since, and particularly in the context of what we heard as a board recently from about population health, and just really understanding some very robust national research that is telling us that children who grow up in care are 4 times more likely than children raised by their parents to experience poor health 30 years later in their lives. And I'm really just wondering if there's an opportunity for us here to bring this group of children who are brought up in care into our future thinking and planning about population health and what that means for us and the system in the way that we work going forwards. So I appreciate that's not a direct question for you, Dan, but it's really a question to see whether there's an opportunity for us to make sure that's included in our work on population health going forwards.
Yeah, we'll take that separately, Karen, maybe pass on to our public health consultant. Yeah, thank you.
Thank you.
Thanks, Chair. Thanks, Dan, for the report and the overview. Great to hear you speaking about lived experience and trauma-informed approaches, and that's so important, isn't it, for this group? So really welcome that discussion to be highlighted with board. Like Sarah, I had concerns about the 24/7 cover model with one person. You know, I'd be interested to just see the quality of the service that can be provided on an ongoing basis for this group. My question is, and it was highlighted in the report on 2 occasions about the multi-agency working, and specifically the information sharing, the protocols, the practice, just acknowledging that this is sensitive information, but I'm just seeking assurances that our core partner information sharing is up to scratch in terms of where it needs to be to support this group effectively.
Yeah, thank you very much for the question. I mean, this is something, of course, that we look at and we develop all the time. It's a rolling program, isn't it? But we work, I think, by bringing the ICB into our own governance framework. We work collaboratively with the ICB safeguarding team, which have that overview and oversight, insight into what's going on in our region. I think we're quite comfortable that there's a really effective information exchange going on, both down from them and from us to them. I'm not sure if it's answered your question, Adrian, but I'm
just seeking reassurance in terms of I mean, we might have good protocols in place, but is the practice actually proving effective? Are we actually seeing a seamless exchange of data which supports effective case management so that people are not getting lost in the wash and they're being exposed to further safeguarding and issues and trauma, and we're actually upholding our duty in terms of child protection?
I think I would do it a disservice if I answered just kind of off the cuff with that, but I'm happy to come back with something that's prepared. We work through very updated policy and procedure with colleagues across the region. So I'm comfortable from that perspective that we have a framework and a structure and an expectation around escalation and information exchange. But I'm happy to come back with something a bit more thorough.
To the quality committee. Yeah, sound right.
That's great. I think this is both a real risk and a reputational risk, which we just need to be aware of and just need to ensure that we've got full oversight of. Thank you.
So Dan, outside of the board, if you just contact Sarah as Chair of Quality and go through it in more detail there.
Will do. Thank you.
Carrie, please.
Dan, I just wondered in terms of digital transformation, what we're doing around these children in terms of on page 164 at the bottom, some of the feedback is that they have to keep telling the story over and over again. And obviously these are children with traumatic childhoods. So we don't really want them to have to keep doing that. So I just wondered if there's any digital plan there that they can capture that information centrally and people can just read that instead of asking the same story over and over.
It's a really good point. Thank you. The audit kind of review process that's been conducted by the ICB and their feedback to our board, that was highlighted as an area that we needed to work on or identify where improvements needed to be made from that perspective as a ICB. So yeah, it is at the front of the work that's been doing to review the efficacy of this service.
Thanks, Carrie. Karen, is your hand still up?
It was, Mike. It was just to highlight. I don't know if you can see this in the room. I saw Donna just popping a couple of comments in the chat, which I think were illustrations of close working between the specialist colleagues Dan's been describing and maternity colleagues. So I just wanted to highlight that so that Donna's contribution there wasn't missed.
Minutes.
We'll capture that.
Yeah, we'll capture that in the minutes, Karen and Donna.
Lovely.
Thank you.
Thank you.
Any further questions to Dan? No, happy to accept the paper for assurance purposes. Dan, thank you. Thanks very much. Okay.
Thank you.
We'll move on then. Item 194, report from the Transformation Improvement Board. Just to contextualise it, board members will be aware this is part of our transition to business as usual, using the auditing term, where some of the responsibilities of the Transformation Improvement Board are in the process of transitioning to be the responsibilities of other committees. The meeting was held in February, and this is for us to receive an update on progress. Deputy Chief Exec.
Thanks, Chair. So I take the report as read, and actually I just want to make one comment really around the sustainability report section, which of course is the part of the report which relates to the process by which we wind down the old recovery support programme infrastructure and assure ourselves about sustainability alongside the handover to business as usual processes operating through the committee. This process is progressing well and is as intended. Just one point of clarification really to make about that, which is that we've signalled in the report review deteriorating patient metrics. Just wanted to clarify really, this review is to ensure they are outcome focused or as outcome focused as possible. So we feel that we can enhance this. And just to assure the board, therefore, that whilst we do that, we will continue to review the existing work stream metrics, and we've scheduled this for the Transformation Improvement Board meeting in April. So just to clarify that, otherwise, Chair, happy to take that. Any questions?
No action points for the board. We just have to consider the report. Okay, colleagues, I'll open it up. Sarah.
Thank you. It's not a question actually, Chris is aware of this, but I just noted under the sustainability section 0.6 that niche is not covered as part of the RSP exit criteria, but actually we did have a couple of actions that had scored, a couple of the actions where the scores were only assigned 1 by the NIAF score provided by niche. And so I just was checking through with Chris and with Richard Sachs around where we are in terms of assurance on progress with those. And it's just to confirm that that's actually the niche report's coming to Quality Committee in the next meeting, so in March. So I'll be able to report back on that as part of our 3A's report from that committee.
And then quick one from me. There's also a section of the report that's asking the TIB to Transformation Information Board to continue to April. Just to clear up some outline arrangements, is that right?
Chair, yeah, what that's about is that some of the reviews, and this is the process operating properly. Having gone through the review, we identified some areas where we wanted to look at different data or perhaps review some of the evidence for a further period. So in that instance, we've rather than close down the RSP work stream and so that Transformation Improvement Board becomes focused entirely on the new Transformation Improvement work streams, we hold that until those reviews are completed. So that was the subject of executive director discussion at the Transformation Improvement Board. Important that we advise the board that we've made that decision, and we will. The process still operates to a conclusion through that route.
Got it. Thank you. Colleagues were asked to consider it. Happy to accept the report. Yeah. Thank you. It's coming now to 10:20. We're a bit early. Shall we have a 10-minute break before we move on to performance? We reconvene at 10:30.
Yes.